So today my talk is on management of diabetic retinopathy or diabetic retina. These are my financial disclosures. So when we talk of diabetic retinopathy, we're starting from diabetic retinopathy, non-proliferative diabetic retinopathy changes to proliferative diabetic retinopathy. A fourth of patients will have PDR by 15 years of onset of diabetes. So the two sight-threatening diseases that we treat are diabetic macular edema and proliferative diabetic retinopathy. So when we talk of diabetic macular edema, we always think of the inner retinal circulation that is at fault. So you can see here the blood vessels situated as the inner blood retinal barrier. If a microaneurysm occurs in the inner retinal layer, you can see how the fluid then tracks down towards the outer retina. But if you see a cyst in the outer retina, most of the time it is from the inner blood retinal barrier, but it can also be because of the breakdown of the RPE cells. Based on this, we have to decide our treatment. And our first type of treatment that is still very frequently used is macular laser. So I'll go through the type of laser, threshold versus subthreshold, patterns of delivery, and limitations. So we all know for a non-central involving diabetic macular edema, macular laser is still the treatment of choice. So if you see a focal edema, of course, we try to do the laser around the focal, at the microaneurysm or around it to decrease the leak. On an OCT, as mentioned in the previous session, you will see an intraretinal cyst accompanied by the microaneurysm. In this case, it may be central or non-central, but if it is non-central, again, our aim is to do laser. There are publications, including one from India on Navilas laser, as well as subthreshold laser using micropulse. There are small studies, and therefore we are not very sure whether subthreshold laser is any better than threshold laser, except that in subthreshold laser you do not make much scotomas, and therefore may be more patient-friendly than a threshold laser. This is an example of a micropulse laser, but you can see that by the end of it, you definitely still see scars. For ETDRS study was the first study, and of course it shows that by 3 years, 50% of the patients will have less moderate visual loss as a result of laser. So that is several years ago. What do we see with our macular laser audits done these days? Again, the mean visual acuity change in 12 months is very minimal, but at least by 3 years, it seems to catch up with anti-VEGF therapy. Approximately 15% will gain vision and 10% will lose vision. That is 15 letters or worse. We usually give around 2 to 3 sessions to completely cause resolution of the fluid, but sometimes we do need to give more. So what are the issues with macular laser? First of all, there is a wide variation in the laser delivery and uptake. Especially with micropulse laser, we tend to give a lot more burns to produce the same effect. Laser therapy can cause loss of vision in eyes with very good starting visual acuity, and therefore most of us tend to observe those eyes to await them getting worse to treat with anti-VEGF agents. It is extremely difficult to do laser in parafoveal lesions when the visual acuity is very good because it results in scotoma. Central edema, if there is a choice, our choice is anti-VEGF agent, and if it is not available, of course, we'll have to choose laser. Macular ischemia is another area where laser is contraindicated. So when do we do laser today? In a setting where there is a lot of anti-VEGF funding available, we will reserve macular laser to non-central involving macular edema or center involving macular edema where the thickness is less than 400 microns, and that's our restriction in the UK. Made by the government to restrict its use. Pregnancy, of course, we try to avoid anti-VEGF agents in these situations. And of course, a recent cardiovascular event, we tend to wait for 4 months before we reinitiate anti-VEGF in these patients. And of course, we have to give informed choice to the patient that both laser and anti-VEGF are available, especially in a country where patient has to purchase or buy the anti-VEGF agent. macular laser may be still the standard of care. Now coming to anti-VEGF therapy, it is now the gold standard for center involving diabetic macular edema. Instead of the figures you saw previously with macular laser, here 50% of the patients will improve 10 letters, 30% improve 15 letters, and it's a very good result with anti-VEGF. But we do need a lot of injections. You can see from year 1, patients are seen every month, have their visual acuity done, clinical exam done, OCT as well. Fluorescence is done at baseline, and we also try to do an HbA1c at baseline. But you can see that we give an average of 9 injections in the first year. Only if this is possible should we initiate patients on ranibizumab therapy, because most often we waste the money and the fluid comes back and we still have to laser. So we have to be very cautious when talking to the patients. In the year 2, of course, we still see them quite often, but 8 weekly this time. And we see that we do a visual acuity and OCT at every visit and inject if necessary. What are the issues with anti-VEGF agent? Of course, you need lots of injections the first year, and then it reduces in the second and third year. We must be willing to see these patients every month at least for the first 6 months. And maximum therapeutic effect is achieved only when we see these patients every month. Patient compliance is, of course, very important, and the service provision to deliver these injections should also be appropriate. The issues with us in clinic is that the visual acuity does not correlate to the OCT, and many a times you will see these type of graphs when you look at the OCT. Some visual acuities are very, very well improved, but the thickness will still be there. So we have found, the DRCR group have come up with 4 phenotypes of response as a result of anti-VEGF agent. Most 50% of our patients will be early and consistent response when given every month for 6 months, but early but inconsistent response in 14%, and you will see non-responders are present in 1 in 5 patients. So we have to be very careful. Even in patients where regular injection was given, 1 in 5 do not respond. So when do we stop treatment? Of course, when macula is dry, and after 3 injections we stop. After 6 injections, if it is still wet but the visual acuity is improved, we tend to stop. I got the third one wrong, but I'll leave that. No response in anatomy at 12 months, and then you develop a microvascular event while on treatment, then we have to stop. What is a broad stopping rule? If the visual acuity is lost by 10 letters or the macular thickness is still above 400 microns at 6 months, then we stop, because we feel that there is no point giving more lasers. But if the visual acuity is very good or the macula is dry at 6 months, then we call it a success criteria and stop treatment. So sometimes we are unable to decide whether or not to continue, and people tend to look at outer retinal integrity to restart a patient on treatment. However, in many patients we do not see this outer retina because of the fluid, and therefore that is not a reason why we should, that should be considered when we restart therapy. It must be other factors. Other causes of poor prognosis are, of course, epiretinal membrane and vitreomacular traction. These are very difficult conditions to treat. We must always remember, if the macular edema is occurring in one eye, that diabetic retinopathy is a bilateral disease and peripheral retina has to be monitored. Color photos have to be taken regularly, and at least 6 monthly checkup of the other eye. And you must remember that PRP may be required although the patient is on anti-VEGF therapy. We do give steroids for them, but we only give steroid as a second-line agent. Sometimes intravitreal triamcinolone, Ozurdex, or fluocinolone. So in Ozurdex, of course, we give it in only pseudophakic eyes where there is persistent macular edema after anti-VEGF therapy. Iluin is long-acting. I think it's not available in India. This is given sometimes when patients respond to Ozurdex but need a lot of them. What do we do when you have cataract surgery, require cataract surgery with diabetic macular edema? We tend to give steroids at the time of cataract surgery, but you also can give anti-VEGF at the time of cataract surgery. 1 There is often a question asked when there is persistent diabetic edema whether peripheral laser will be sufficient to reduce the edema. So far, the evidence is relatively poor, and we do not recommend that. But it may be needed in a patient-to-patient basis. So when we think of anti-VEGF agent for diabetic macular edema, it is still the first choice for center-involving macular edema if one can afford it and the service can deliver that every month. Long-term effects on the neurons are still doubtful. There is the combination treatment may be the way forward, that is laser plus anti-VEGF or anti-VEGF followed by steroid. But treatment therapy should be individualized, and several questions still remain unanswered. We did do a trial on aflibercept for anti-VEGF for proliferative diabetic retinopathy called the Clarity study. Here we found that aflibercept is actually superior to laser for panretinal photocoagulation. However, although very few injections were required, we must remember that the new vessels do come back once anti-VEGF therapy is stopped, and therefore we have to add panretinal photocoagulation as soon as we decide to defer aflibercept therapy. And lastly, we should not forget about systemic treatment. Our diabetic control is crucial. We remember the metabolic memory that we have seen in the DCCT and the EDIC trials that show that patients do continue to have diabetic retinopathy because of previous poor control in diabetes. Hypertension is a very important effect, and that has to be reduced, and so are lipids, according to the Accord and Field trials. So in the US, when such a study was done, you found that 20% of the patients with diabetic retinopathy had very poor control of their primary risk factors of diabetes, hypertension, and hypercholesterolemia. There are new treatments coming our way, and I think the Panorama study and the DRCR Protocol W that now shows that anti-VEGF can even be given in severe non-proliferative diabetic retinopathy. Again, it's fully challenged because there is no way one could afford giving this treatment forever, and we do need new treatment options for these conditions. Thank you.